Gonna give it a few minutes and see if anybody is having trouble. Um, we'll be starting promptly at around 9:40 or 9:45, just so everyone can join this event. So just a couple more minutes, um, just to see if anybody is having trouble. Um, this is somewhat, a little bit troublesome for some people to get connected. So I'm going to just give it a couple of minutes here and see if anybody's having any issues or anything. You can list it in this chat box on the side, and I will see what I can do. Let's wait for two more minutes. For those who are already in the queue during this presentation, um, Just give it another minute or so and then we'll get started here. So just to introduce myself, my name is Nehal Desai, and today we're going to be looking at Parkinson's. Oh, actually, you should have spelled it right. Parkinson's disease overview as part of this NAPLEX review um, course. So, what is exactly Parkinson's disease? Um, Patients that are having Parkinson's disease are usually those who have a very little amount or who are not able to um, respond to certain things. So um, you can just think about it in short as like having a lower amount of dopamine um, in the or dopamine stimulation, you could say, where a patient is not able to act upon anything that, as you know, is rewarding, like as dopamine does. Um, so in this case, Parkinson's disease, patients going to have more of this um, tremors and rigidity um, when they are experiencing those symptoms. So, what can lead to tremors? What leads to those tremors is usually when there's too much excitatory glutamate or NMDA receptor interaction with that glutamate receptor. So, um, and there is very little amount of, you know, inhibitory action. So, in this case, you'll see a lot more loss of dopamine neurons in the substantia nigra. So there's some sort of dopamine neurons, and these dopamine neurons are um, much less than it should be, at an amount where certain activities that's performed is actually not working well for those patients. So in this case, when there's dopamine loss, there's movement problems. And that movement problems could, patient is probably maybe able to move, but, they might not be able to control certain movements. So they're going to have some sort of tremors, rigidity. They might have a little bit of other types of movements, akinesia, bradykinesia, postural instability. So these are kind of like uncontrollable movements. Um, so there needs to be a balance between, excitatory and inhibitory actions in the brain. So, and a lot of times when it comes to the Parkinson's disease, it actually deals mostly, within the basal ganglia, which is like the right there in the little core part of that brain. But we'll get to that in the later sections. My main focus in this overview presentation is to go over certain treatments in Parkinson's disease in helping replenish that dopamine loss that a patient has when they are in the Parkinson's disease state. So that's basically all it is. And a lot of times, the most common symptoms you would see on a case, um, on an exam, on a case-based question, maybe when you see patients asking about it, this is usually the top symptoms that patients will have. And so just look out for these key terms. And I do not, uh, you might not get too many questions on this, but it is at least good to know, especially in practice as well, when you're helping patients. Um, I also wanted to let you all know that, do not get confused between Parkinson's disease and um, Alzheimer's disease, okay? The treatments are different. Um, Alzheimer's is the dementia form, like the loss of, memory loss and things. This is the movement problems. So do not get the two mixed up. So let's take a look here and see what the treatments are. The first line, the most common treatment that most Parkinson's patients would receive is levodopa and carbidopa combination. And we'll talk about this combination more in depth, but at least three of these classes are going to be shown on one image. So you will all be able to see how it works in a big picture. So you could see how dopamine agonists, you'll have something like ropinirole, pramipexole, rotigotine. Those are some examples. The monoamine oxidase B inhibitors like selegiline, resalogine, the catechol O methyltransferase inhibitors. These are things like entacapone, tolcapone, and then the anticholinergics like benztropine, trihexyphenidyl, and then the last one I will go over is the amantadine. So of all of these, I feel like you're going to see the whole big picture with some of these classes here. These two, the monoamine oxidase inhibitors and the COMT inhibitors, or the catechol methyltransferase inhibitors, are very much similar in terms of the mechanism. So I'll show you that in the slides here, and you'll see how levodopa carbidopa works as well. But before we get started, the first thing I wanted to ask, does anyone have any questions before we start going over these treatments? And so if you don't have any questions, let's continue this review. So let's take a look first at the basic concepts. Many times, whenever you take these kinds of medications, they have to cross something called a blood-brain barrier. Now, what is a blood-brain barrier? It's essentially a barrier that prevents certain ions or certain substances from crossing into the brain from the bloodstream. So, whenever you see something like something more lipophilic substance are typically going to be able to cross through the blood, cross to the brain, versus something that's more polar. And so we're going to take a look at some example images here in a second, but it is very important to at least have a basic understanding of a blood-brain barrier, because a lot of times this is where all of these medications come into play. So here you see here And I want you to take an image and I want you to take the time to at least draw out a diagram of your own. And just picture how this blood-brain barrier looks like. So you can see here in this image where there are kind of blocks and squares and those things. Those are their endothelial cells. The endothelial cells are basically the true barrier between that blocks the flow of certain substances and ions and those kinds of things and certain medications from crossing into the brain. And so you can see here these little square blocks with the uh, uh, that like looking like those cells, or you could like bricks. You can't get on the other side of that wall. So this first picture here, right here in this, where you see the astrocyte end foot, the periocyte, the peg socket. This is kind of like a if you take this whole thing and make it into a round shape, you could see how this is the blood-brain barrier. The endothelium is right there. So it's just kind of like um, a very simple diagram. And why am I explaining this? Why do I even care about this? Well, in order for these medications to work, they have to get to the brain. And otherwise, we cannot, the brain is responsible for a lot of movement, hearing, vision, everything. And so, without the process of getting the medication to the brain, without having this to enable medications, are useless. They have to get to our brain in certain ways. And we'll look at that in a second. There are certain transporters it has to go through. And these transporters are actually located right there on you can see at the endothelial cell in those places. So I wanted to show you a quick diagram here on the right side to show you that there are tight junctions that also protect the brain from getting some unknown substances and things like that. And as I mentioned before, like the neuron is when you in school they probably taught you like looking at neurotransmitters like this. You're connecting two parts of the neuron 1, neuron 2. But in reality, you're looking at this thing kind of like as a dendrite. Okay, so like let's take a look again. Like you see how it's kind of like a little hair sticking out of the head here. You could see here little hairs here, kind of like this. I kind of like to illustrate these things for you all because some of you guys might be struggling with this, a little stuck with it. So I hope that this is kind of helping kind of visualize and see things a little bit better. But you should try and draw these things on your own too, so it kind of help you understand how these mechanisms work. So this typically you would see a lot of this is like the dendritic part or the dendrites. Okay. Now where's the axon? The axon is this part right here. This is the axon. Okay. All right. So, and then this part right here, this is the axon terminal, or part of the axon terminal here. So what's happening here? So this part right here is usually that neuron 1. And then this part of the other neuron is part of neuron 2. So just wanted to show you a quick diagram of the basic function of the neuron so you could see how it kind of connects here. Um, so a lot of times, the medications are going to be going through this process and, associating between different neurons and, allowing these action potentials and stuff doing for, doing its work as it needs to. But for the purposes of this presentation, I'm only going over these treatments with you all because I am sure you guys, by the time you see this, you're probably going to remember this one picture for a lot of the treatments. So used for Parkinson's disease. You can ask your colleagues a question about it. You can use this images as a review. It is these are medications that you would see patients taking from time to time when they need to get that dopamine running in the system. So this is the big picture of the Parkinson's disease. Is when we talk about mechanism of action for almost every medication that is used for Parkinson's disease. So here on the left, you can see I labeled it as 1 and 2 because I want to magnify the visualization of this part of the picture here. Now I kind of drew out my own personal diagram just to make it a little bit simpler for you all to understand the endothelial barrier that plays a role in the blood-brain barrier and all. And I kind of drew a few things here. The first thing I drew, because we are talking about levodopa, carbidopa, is the L-dopa or levodopa. You can see how the levodopa is actually within the blood and is trying to get to the brain. So before it gets to the brain tissue, a lot of times levodopa by itself cannot be taken because levodopa is going to be broken down in the process. And here's what happens. Levodopa gets converted into dopamine by dopa decarboxylase, which is one of those enzymes that you would find floating around in the blood and brain. So, and why levodopa breaks down? Levodopa is essential to, you know, um, in the process of replenishing the dopamine inside the neuron. So when levodopa gets broken down into dopamine, dopamine won't be able to get into brain tissue. And so levodopa can get through brain tissue. Now why am I saying this? Dopamine is one of those, natural precursors. You're not going to be able to move it into the into the brain tissue. But dopamine agonists, because of the synthetic nature of those kind of medications, they are going to be able to cross through the blood-brain barrier. So do not get those two mixed up. Another thing I want to mention here is levodopa also gets broken down into 3-O-methyltransferase methyl-dopa as well. This is where the I don't know what happened. Okay. I think we had a little bit of trouble here. Does anyone have any issues so far? Okay. So what I was saying is you see the levodopa here, the L-dopa. you could see how it's kind of the dopa decarboxylase breaking down to dopamine. And dopamine is very important, it needs to be used, but it has to be used inside the brain. So what do we have to do? We have to use carbidopa so we can block the dopa decarboxylase from breaking it down from L-dopa to dopamine within the blood. So levodopa is going to um, uh, stay in the system, in the blood, so it doesn't get broken down because of the carbidopa. So stay longer, and then it will make its way out to the brain tissue by a transporter um, between these endothelial cells and within these gaps. So you could see how it's kind of coming out, and then the end result is it's going to convert to dopamine. But let me show you the little magnified process here. You can see here in this process here, and I'm going to kind of write it out so you guys could see number 2 here. Number 2 is right here in between what's happening here. When levodopa comes out into the brain area, it's going to be stuck in some extracellular part of the brain, and then the dopaminergic neuron is going to use an amino acid transporter and transport these levodopa particles inside the dopaminergic neuron. Then you're going to have some conversions that occur where uh, this dopa decarboxylase will convert into dopamine, and then dopamine can finally work in the brain to release it to the post-neuron synaptic area. And, dopamine, as kind of like how dopamine agonists work, it will bind to the D2, D3 receptor, and um, patients can get their normal movements again, and all of that with the dopamine replenishment. So technically, that's what's occurring in this diagram. Carbidopa is basically just blocking that breakdown of levodopa into dopamine inside the blood area before it gets into the brain. So I want to kind of show you that. The next diagram I want to show you here builds upon the previous diagram, where now you have dopamine, right, converted. But what is happening here? What else is happening here? Okay, so there's these other particles that also flows within the dopaminergic neuron, dopamine neurons, where it's called a monoamine oxidase and monoamine oxidase B. So you're going to see here that is going to actually break down or eat up the free cytosolic dopamine that's converted from levodopa or reuptaken from a synapse via the dopamine transporters. So you can see here, like, okay, so you got the dopamine, but you got some dopamine that's going to be in the vesicles, and you have or the VMAT, and then you have those other dopamine particles that's going to be free in the cytosolic area of the neuron. So those are the ones that's going to be eaten up, or those are the ones that are going to be reduced in a neuron by this monoamine oxidase. And that's where the monoamine oxidase B inhibitors come into play to prevent that breakdown of the dopamine and to, keep it, not to prevent it from being broken down or from being reduced in the brain. So that's what's happening here in this area. Then you got catechol methyltransferase, and I kind of mentioned this a little bit, but levodopa breaks down in one of two ways. It either breaks down to dopamine, or it's going to break down into 3-O-methyl-dopa inside the blood. So the COMT inhibitors is going to prevent that breakdown of the levodopa into the 3-O-methyl dopa, which is totally useless. It's not going to replenish the dopamine in the brain. So that's what's happening here. And then what happens here now, another medication I want to talk to you about is, and let me just retype this out, is amantadine. Amantadine is going to be used to do one of two things. Amantadine is going to promote the use of dopamine so that I can go ahead and start connecting with the other neuron, quickly and, efficiently. And the other thing amantadine is going to do is going to block the excitatory glutamate receptors, or the NMDA receptors, which is really something we would want, is to decrease that overexcitement and level it with the inhibitory mechanism, or the dopamine mechanism here. So let's kind of not be overexcited here with that movement. Let's kind of slow that down and also increase our dopamine use. So that's what amantadine does. It's kind of like a dual mechanism here. Amantadine is going to block that receptor, which is on the post neuron synaptic area, and then it's going to work on allowing more of that dopamine to cross through. And then this last one is the anticholinergic area, which I kind of drew out here, a magnified diagram showing how in the basal ganglia you have like the two neurons, and then the anticholinergics will work on the M1 receptor to also help in assisting with like the movement and all, and preventing the over movement, or the uncontrolled movement and tremors within the basal ganglia. So those kinds of things. And that's pretty much it. Does anyone have any questions? This slide was not supposed to be here, and I will remove that. You guys are all free to go. I do think you guys should take this diagram, kind of redraw it on your own, because I think this will kind of explain the big picture of many of these medications and how they work and all. And I know how difficult the exam can be for you all. So I hope this kind of clarifies certain things about the mechanism of action of many of these Parkinson's disease treatments, and also take the time and use it as a review. And if you have any questions, feel free to let me know in this chat, or you can go ahead and let me know via email, comment. Try not to send the email. The email isn't really going to, we might not be able to get to you on time, but you can reach me at on our YouTube channel. You can reach me, if you have any other questions, on our Facebook page as well. So feel free to let me know if you have any other questions. I hope this video has been helpful to you all, and Have a good day and see you all soon. And thank you for watching.